So that Good afternoon, everyone. Good afternoon, everyone. I am Dr. Shripad Jimihangale, Professor and Head of the Department of Anaesthesiology at KSAGDA Medical Academy. I am very, very glad and very happy to welcome all of you to this Nitte Anaesthesia Education Series, an online academic event to train postgraduate students in the nitty-gritties of anesthesia. This is our 12th episode. We started in the last 2021 August. Since then, we covered cardiovascular system, respiratory system, a little bit of renal system, and now we are coming to hepatic system. And I'm wholeheartedly welcome all our old participants, whether it is faculty or the students or the presenters, all who joined with us. You made the event linger on for 1 year. Thank you so much for that. And I again welcome all of you back to this 12th episode. Today we have a special episode where we deal with hepatic physiology and liver transplant. And we have one of the best faculty with us today from Dr. Lakshmi Kumar, Clinical Professor and Head of the Department of Anaesthesiology and Critical Care at Amrita Institute of Medical Sciences. And she has a vast experience in various aspects of anesthesiology and critical care. And particularly, she is doing the services of liver and solid organ transplantation, then gastrosurgery, including hepatobiliary and upper and lower gastrointestinal tract surgeries, pediatric and neonatal anesthesia, and also critical care. So you can understand the vast knowledge and skills she is possessing. And so she fittingly going to deal with the most important physiology in the body, that is hepatic physiology. And thereafter, we are going to have a discussion on a patient coming for liver transplant with terminal liver disease. We have Dr. Gurudat CR, who is a professor and head of the Department of Anaesthesiology at JSS Medical College and Hospital, Mysore. He has been working in this institute for last 7 years. Before that, he has served in many other places, including Government of Karnataka, where he served at Mysore Medical College and Research Institute. Before that, he was at Vijayanagara Institute of Medical Sciences, Ballari, and so many other places. He also has served Indian Army. Again, so we have people with different hats. Then with him, we have Dr. Shivani Kamath. Earlier, she was Shivani Kudwa when she was with us at Kshema as a postgraduate student. Now she is working at Reliance. She is Shivani Neeraj Kamath, consultant anesthesiologist and a specialist in liver transplant and obstetric anesthesia at Department of Anesthesia and Pain Management at Reliance Foundation Health Center at Mumbai. She was trained at Medanta Medicity under leadership of Dr. Vijay Vohra and Dr. Arvind Swain. Thereafter, she joined Justlock Hospital, Mumbai, where she was lead anesthetist for all liver transplants, including high risk and pediatric transplants. Then she was trained at Queen Elizabeth Hospital, Birmingham, in UK, and obstetric fellowship at Birmingham Women and Child Care, Birmingham, United Kingdom. After the case discussion, we are going to have a brief discussion on anesthesia cylinders, anesthesia gas cylinders by Dr. Anand Bangera, our former head of the Department of Anesthesiology at KSAGDA Medical Academy and senior professor in anesthesiology and critical care. He is very fond of, he is a student of Dr. Gurudat, and both the teacher and the student are very good flair for teaching. All the students who had interaction with them, they are fida for their talent. Sorry, with the good sense of humor and eloquent teaching skills, he can mesmerize anybody. So we have a very grand faculty today. Sorry. I don't want to be between the academic extravaganza and our audience. I again, sorry for the bad throat. I again warm welcome to the faculty, the students, the audience, my colleagues, our organizing secretary, Dr. Suma, faculty, and everybody. Sorry. Over to Dr. Lakshmi.
So you'll have to let me share screen. All right.
I'll make you the host.
Yeah.
I'll make you co-host, so I think you should be able to share.
Yeah,
this.
Because it's going to your desk or your laptop now. It's not.
Not sharing. You will try now. Not able to. Okay, I'll make you host. Are you able to share? Yeah, we can see your screen.
Yeah, we can see. Madam can go ahead with it.
Yeah, you can see your screen, ma'am. May I please go
Hear
ahead?
anybody else? Yeah. Shall I go ahead?
Yes, yes.
Thank you. Okay. If people can hear me, right?
Yes, madam.
Yeah, very
Okay.
clear.
Right. Okay. I'm sorry that the internet is not great. Okay. So good afternoon, everybody. And thank you, Dr. Sripada and Dr. Suma, whom I'm sure was instrumental in pushing my name for this. Thank you once again. I think I was part of your academic proceedings a year ago. And this is one of my familiar topics. And each time I prepare, I learn new things. So, it's just not the students. I stand to benefit each time I do this. So I'll just move on to hepatic physiology, and I'm trying to base it to what the anesthetist might find interesting instead of going through the basic anatomy physiology, right? So the model for my discussion is structure of the liver and how it has implications for us. Segments of the liver, how does that deal with hepatectomy surgeries that are being performed? A discussion on the unique blood supply of the liver, the metabolic functions of coagulations, and summary, conclusions. Okay, so we'll start on, and this is an all very familiar figure with all of us would have read through our MBBS and back again in MD. So just for us to recapitulate, the liver is the largest and the most versatile internal organ, weighing about 1.3 kilograms. We all know that it has a dual blood supply from the hepatic artery, which is the arterial, and the venous system, which is formed by the confluence of the superior mesenteric and the splenic vein joined to form the portal vein, which supplies the liver. And the nerve supply is from the postganglionic nerve endings from T5 to L1. So when you're asked in the exam, or we ask ourselves, what is the functional unit of the liver? It is a liver lobule. Now, when you talk of the functional unit, this image should just come automatically to everybody's mind. You have a hexagonal diagram, And each of the points, the corners of the diagram, is what constitutes the portal triad. And in the center, you have the centrilobular vein. So the portal triad contains the hepatic artery, portal vein, and the bile duct, besides other structures. And intuitively, the areas that immediately adjoin the portal lobule are the ones that get the maximum blood supply. And it recedes, the blood supply decreases as you go around the central vein, which is located in the center. Right. So based upon this, there are zones of perfusion. Zone 1, which gets the maximum amount of oxygen. If you have hypotension or hypoperfusion, this will be the last to get affected. However, this area becomes involved in ischemia reperfusion injury when there is a total inflow occlusion during some types of hepatectomy. The zone 2 is actually a buffer. So what doesn't get oxidized in zone 1 comes to zone 2, and the remnant or the leftover is what percolates down to zone 3. And if you look at a microscopic structure, this is what you are supposed to find. The portal vein and the central lobule distant from each other, and it is surrounded by acinar cells. So let's see what this means to us. Like you might have commonly seen, 68-year-old man comes to the emergency room with acute onset of abdominal pain and is in shock. So an ultrasound shows there's a ruptured aneurysm, and without much ado and investigations, he's rushed for surgery. The surgeon puts a clamp, things are okay, patient recovers and is shifted to the ICU. But on the first post-operative day, besides his lab and platelets, you find that the enzymes are elevated. AST is 2,100, ALT is 1,980. And this is typically what happens when there is a ischemic hepatitis, or this is the consequence of a depletion of oxygen transiently to the hepatocytes. This may also be seen in hepatectomies and hepatic resections. And the larger the magnitude of the enzyme rise, the greater will be the morbidity associated with recovery. So this again, this is just for you to recap. This zone 3 will be the area where the maximum damage can occur. This is another cross section, and here again you'll just see a magnified version of those points of the hex. Can you hear me? Can I keep talking?
Yes, ma'am, you can.
Feedback.
Yes, ma'am, you
All
can.
right.
You can.
Right, thank you. So at the corners of the hexagon are where you see the bile duct, the branches of the portal vein, and the branches of the hepatic artery. So when we apply this to our practice, as I have already said, zone 1 hepatocytes are those in the area immediately surrounding the portal vein, which receives oxygen-rich blood maximally. It's only the supernate and surplus from that goes, right? Zones 2 and 3 are called the reserve pool if hepatic dysfunction exists. Now, as I said, zone 3 would come near the portal vein, and therefore it's most vulnerable to hypoxia. Now, the important thing about the hepatocyte and the SNS is that these hepatocytes regenerate by mitosis, and they can recover to about 70% of their original volume. This makes living donation possible. And as I go through the segments of the liver, you will understand in what is being done as an adult living donor hepatectomy, nearly about 70% of the liver will be removed. And how is it that we are safe doing it to a donor who has no need to undergo surgery? Is because the remaining 30% will grow to the size nearly 80%, 90% of the original liver in a matter of 3 to 4 weeks. So this mitosis and the ability to regenerate by mitosis is the reason how living donation becomes possible. Now, so having spoken about the lobule, the liver lobule, we look at the microvascular unit of the liver, which is called the SNS. So this SNS, you can see, crosses the portal vein at one end and the central vein at the other. And you have on this the hepatic endothelial cells, the hepatocytes, and the hepatic endothelial cells. Now, the hepatic endothelial cells are unique in that they do not have a basement membrane, and they allow the percolation or the transfer of lipoproteins and albumin across the space. Between the endothelial cells and the layer of hepatocytes is a space that is called the space of Bisi. Previously the cells ETO cells are now called as the stellate cells. Stellate cells in normal health are nothing but mesenchymal cells. But during the times of injury, as it happens in cirrhosis, the stellate cell changes its function and diversifies to synthesize collagen matrix of different types of collagen. And when you look at this, you can see the portal vein, the central vein, and the hepatic sinusoids. So you know that the pathophysiology in portal hypertension is essentially an obstruction to the outflow of blood from the sinusoids, thereby increasing the efferent resistance to blood flow. And when this happens, this obstruction is further compounded by the ramifications of collagen from the stellate cells, which will interfere with lymphatic drainage occurring in that space. And this is the pathophysiology that contributes to the occurrence of ascites in cirrhosis. So this is a schematic picture. You will see the normal stellate cells, which their ramifications existing in the space of DISI, and all is good. But see what happens in cirrhosis. It becomes bizarre, it hypertrophies, it forms a matrix underneath and actually obstructs the outflow of lymphatic and thereby contributes to ascites seen in cirrhosis. Now, another common thing that you should know is alcohol. The most common cause of cirrhosis coming for transplant today at our center, and probably most centers in India, remains alcohol. Now, while it is true there is a genetic predisposition to alcohol-related injury, the pathophysiology of the damage starts from here. Alcohol-induced gut vasodilatation increases the permeability of the endothelial cells that we previously saw and allows the transport of gram-negative bacteria, which normally would have been filtered by the Kupffer cells, into the portal systems. There in the portal cells, this Kupffer cells is actually activated by these lipoproteins to activate several inflammatory mediators, and among them the aldehyde component and other inflammatory mediators mediate the process of hepatic cell destruction, which may start with first infiltration of inflammatory cells, progresses to ballooning degeneration, third is hepatic cellular destruction, and the fourth is resulting in fibrosis, which again is the basic pathophysiology of cirrhosis, which you may be asked in your exam. Right? Now, I'll come to the segmental divisions of the liver and its impact for the anesthetist. So these were the Cunard segments, and today when we talk about hepatic resection and segments, we usually base these segments based on the branches of the hepatic vein. So you all know that there are 8 segments in the liver. Where are they? Yeah, 8 segments in the liver. Essentially, the left lobe of the liver will have segment 2, segment 3, and the large segment 4, which is further subdivided as 4A, 4B. Segment 1 is posterior and tends to hypertrophy in certain conditions such as primary biliary cirrhosis. Then you have 5, 6, 7, and 8. Right? So the anatomy of these segments is important while planning a hepatic resection. And metastatectomy, however, can be done on a non-anatomical plane. This is what I want you to just look at and understand. When you talk of just a right hepatectomy, it is segment 5, 6, 7, and 8. When you talk of an extended right hepatectomy, and most commonly this is what will be done for the living donor, you will include segment 4, leaving behind only segment 2 and 3. Left hepatectomy, like when you take the left lobe for a child or an infant, this would be 2 and 3. And a proper left hepatectomy would include segment 4, while extended would include 2 of the right-sided lobes as well. Right. So the liver is capable of regeneration after resection, which allows us to do hepatectomy with a reasonable comfort that your patient is safe. When you do a right donor hepatectomy, the surgeon will divide the liver along the middle hepatic vein, which is most often included in the graft. And this is what is done when an adult patient donates to an adult recipient. The left lateral segmentectomy is from an adult to a child, left lobectomy for an older child, and split liver grafts can be used for both adult and child. Now, coming to the uniqueness of the blood supply, we have mentioned that the liver is unique in having a dual blood flow, both from the hepatic artery and the portal vein. The portal vein supplies about 75% of the blood flow to the liver, but only 50% of its oxygen, while the hepatic artery, while only supplying 25%, supplies 50% of the oxygen supply to the liver. Now, the hepatic arterial buffer response is a defines a semi-reciprocal relationship of blood flow between the hepatic artery and the portal vein, meaning that when the portal blood flow decreases, it is compensated by an increase in the hepatic arterial blood flow, but the converse does not occur, and hence the word semi-reciprocal. Now, how does this compensation occur? This is because when the portal flow decreases, there is an accumulation of adenosine around the hepatic arterial bed, and this will result in hepatic arterial dilatation. The hepatic artery can about increase to twice its basic blood supply, but not beyond that. So while the hepatic artery compensation cannot restore a volume of blood to the liver, it is reasonably effective in restoring the oxygenation of the liver. The implication for us anesthetists is which of these inhalational agents can abolish the hepatic arterial buffer response. Thankfully, we don't use any of these today, halothane and I think enflurane. The others that we use currently definitely do not affect the hepatic arterial buffer response, but you can decrease the hepatic arterial blood flow just by a decrease in mean arterial pressure, and therefore you should always endeavor to keep the mean arterial pressure above a 65 or a baseline value specific for that individual to avoid further ischemia-related injury during surgery. Now, the 1, 2, and 2, this picture again is from Miller. Alpha-1, alpha-2, and beta-2 receptors and their distribution across the hepatic blood flow system. So you can see that the mean pressures in the hepatic artery and the portal vein are depicted. So the normal portal pressure is actually less than, and it's usually between 5 to 7 millimeters of mercury, while in portal hypertension, it is anything above that. And portal pressures which are more than 10 are associated with the presence of esophageal varices, and portal pressures more than 20 millimeters of mercury can cause a spontaneous variceal bleed. Now, we all know that in a patient with cirrhosis, there is an extreme dilatation of the splanchnic system, which is essentially the blood that goes to the gut and to the spleen. And this compromises the blood supply to a very important organ, namely the kidney. Now, the liver sinusoids are also a vascular reservoir, and stimulation of this in conditions of hypotension or shock can result in the release of up to 400 ml of blood into the circulation. So, as I said, the splanchnic vasodilatation restricts the blood flow to the kidney in patients with cirrhosis who have extreme splanchnic vasodilatation. So, the consequence of this is the kidney perceives a hypoperfusion, activates a renin-angiotensin-aldosterone system, and then it goes on to a sodium and water retention, but still there's a background of hyponatremia because of the increase in extracellular fluid, and you will find a rising creatinine. So, the treatment for this is essentially to cause an increase in the systemic vascular resistance, which is a culprit for this problem, for which we need to give terlipressin, which is the most recommended agent. And you also give a fluid restriction of 1.5, but use proper volume expanders like 20% albumin. And this is the recommended treatment for the management of hepatorenal syndrome or acute kidney injury in the background of chronic liver disease. Other agents, midodrine or epinephrine, have also been used, but the overall consensus is terlipressin with albumin is most effective in restoration of renal blood flow in a patient with cirrhosis. Now, I mentioned some of this, and I think this would be a repeat, so I'm not going to go into it again. Basically, you should know what can actually decrease the blood flow. So I think when I gave lectures 10 years ago, we used to say a PEEP more than 10 can actually interfere with the outflow of the venous blood from the liver. Therefore, we used to be very cautious after transplants to say that the efferent blood flow will be blocked. However, now I think the understanding is changed and allow up to 14 millimeters of mercury PEEP. They say that it doesn't compromise the outflow from the liver. The use of retractors, upright position, and some anesthetic agents per se can decrease the blood flow. But most of the time, maintenance of mean arterial pressure, even as one might see in spinal anesthesia, the restoration of mean arterial pressure by phenylephrine or any other agent would restore the blood supply to the zones of the liver. So among the safety of using a volatile, all of them can decrease the blood flow to the liver, and most of them act because they decrease the cardiac output and therefore the percentage of the blood flowing into the liver. Desflurane, sevoflurane, isoflurane are safest in that order, and halothane, of course, thankfully we don't use it now. Now I'll come to the second half of this lecture, which is the metabolic functions of the liver. Right? I'm just going to, I thought today's topic you were going into ALF. I'm not sure the exam candidates will get ALF. To my knowledge, I thought it was only CLD. But anyway, it is an interesting and a frightening topic as well. So I'll just briefly explain how ammonia is instrumental in causing cerebral injury and why it happens in the background of liver failure. Now, just as a background of protein synthesis, you all know that all the synthesis of proteins happens in the liver, and 12 to 15 grams of albumin is synthesized by the liver each day, right? When there is decreased synthesis or if there's increased loss as a nephrotic syndrome or protein losing enteropathies, then you may have a decreased albumin. The role of albumin is for binding of the drugs, hormones, bilirubin, and metals. Right. The important, when you talk about protein metabolism, the most important bit would be the urea cycle. Now, what is this urea cycle? You have glutamine broken down to glutamate and ammonia. The ammonia enters the hepatocyte and enters into the mitochondria of the hepatocyte, where it combines with bicarbonate and it forms carbamyl phosphate catalyzed by carbamyl phosphate synthase enzyme. Now, carbamyl phosphate gets converted to citrulline in the presence of, it gets converted to citrulline, it combines with ornithine, and it results in the generation of aspartate and essentially arginine, which is a semi-essential amino acid. And in the process, it releases urea, which is then excreted. So the very toxic ammonia is acted upon within the mitochondria and then in the cytosol and is reduced to a non-toxic substance, urea, which is excreted. But what happens in liver failure? In liver failure, right? So I'll come back to my older slide. So in liver failure, you will have the failure of these systems that will detoxify ammonia. So there is an increase in the presence of ammonia in the mitochondria, and therefore the blood levels of ammonia will increase. Right? Now, ammonia per se does not cross the blood-brain barrier. And there is still a lot of conflict as to whether ammonia crosses the blood-brain barrier to cause an astrocyte edema as seen in acute liver failure, or if it is carried along with glutamate. That's called the Trojan horse hypothesis. Like you remember in a wooden horse, a lot of soldiers were hidden, and Troy was there was a battle. So the same thing here. The ammonia is hidden within that and carried by glutamate into the astrocyte of the brain, which contains a receptor and an enzyme. And ammonia will cause the release of substances that will enhance the astrocyte edema. And this astrocyte edema and thereby the cerebral edema is an important pathological mechanism that frightens all intensivists who deal with patients with acute liver failure. So what is its importance? You might have read somewhere that the administration of LOLA, L-ornithine L-arginase, which is a mixture of some amino acids, have the capacity to kind of urge or increase the urea cycle synthesis to detoxify the ammonia that is produced in the body, right? The other is, of course, we give substances that can reduce the cerebral edema, like hypertonic saline, which will reduce the astrocyte edema. But the treatment of hyperammonemia per se is that we go in for advanced forms of renal replacement therapy, continuous veno-venous hemodiafiltration is different from dialysis or other forms in that it can target middle molecules, of which ammonia is one of them, and other inflammatory mediators that are so pathognomonic in causing a multisystemic response in patients with acute liver failure. And and I'm just dwelling on the topic since I realized that was the second lecture in the second half of this session. Okay, so this is just another schematic depiction. And what happens in the urea cycle? The non-toxic ammonia normally in health is converted into urea. The urea cycle produces semi-essential amino acids like arginine. Ornithine is a precursor of some proline and polyamines, which have various roles in cell growth and proliferation. Now, what happens if the liver fails as an acute liver failure and in mildly in chronic liver failure? So here it says that increased levels cross the blood-brain barrier. That is debatable whether directly or indirectly, that is a different topic. Now, besides the astrocyte edema, when ammonia crosses into the brain, it utilizes alpha ketoglutarate as a substrate, decreasing the level of alpha ketoglutarate, which therefore impairs energy production through the tricarboxylic acid cycle. So this is the metabolic or the cellular level of hyperammonemia. We've never really thought of that. We are so worried about cerebral edema and coning or an intracranial bleed. So much for proteins. I'll move on to the carbohydrate metabolism, of which I think everybody will come and say lactic acidosis, lactic acidosis. So what is the liver? Before coming to the lactate, what does it do besides lactate? So when we eat food, you generate glucose. This glucose is taken up by the liver and it is stored as glycogen. So it's a storage, but if you starve or if you do not have enough glucose, the same glycogen is broken down to release glucose. So you have a two-way mechanisms between glucose and this thing. And of course, the starch that you eat is what contributes to glucose. And when the glycogen stores are supersaturated, it turns towards deposition of fat and can result in increased lipids. Gluconeogenesis, when glucose stores are not available, the liver will break down lactate, amino acids, and glycerol to produce glucose. Glucose has a role in the energy pathway to the pentose phosphate pathway, where it generates ribose and NADPH. Anaerobic oxidation of glucose can occur, producing lactate, and then you have the famous pyruvate and lactate. So normally, when we all talk about IV fluids and we say IV fluid like ringalactate has a base which is lactate. So why does it not cause acidosis when you're giving a lactic acid? Is because this lactate is broken down by the liver to bicarbonate normally in health. And during this process, it also utilizes an endogenous hydrogen ion. So it is important to give a fluid that has a base that can be broken down to bicarbonate to preserve the homeostasis of the body pH. And that is why we say normal saline causes a dilutional hyperchloremic acidosis. It causes acidosis by dilution. Another situation that you can have, and this is lactate given extraneously. Now, what happens if you cycle? You do violent exercise, you run a marathon, your muscles produce lactate. Then the lactate again is taken up by the liver and oxidized to pyruvate and can generate energy through the citric acid cycle. What happens when the liver cannot do this function of detoxification? Then the lactate will remain as lactate, and therefore this is a time when you avoid fluids that contain extraneous lactate because the liver cannot handle this. So while the normal pyruvate enters the Krebs citric acid cycle and produces 38 molecules of energy, the use of lactate to generate energy will only yield 2 molecules of ATP. So you can have hyperlactatemia. You go on into an anaerobic force of metabolism in contrast to the normal energy related through pyruvate metabolism, right? Now, when the glycogen stores are decreased, we said that the liver can use a glucose neogenesis. So this is what happens when you fast your patient for 8 hours before surgery and take a good 12 hours or 24 hours before he takes orally. Then what happens? You don't have enough glucose. Here we all don't believe in using, we believe that routine dextrose supplementation in IV fluids is not necessary. This is a PG teaching and many of us practice it. So what does the body do? The body still has to function. So it breaks down proteins. And this protein catabolism is what contributes to significant weight loss and delays the recovery after major surgery, which is why the ERA's guidelines now talk about the need to give a carbohydrate loading in the form of a 12% maltodextrin drink on the night before on the morning of surgery. Now coming to fat metabolism, the liver absorbs the free fatty acids from the circulation. In addition, what is the mechanism of synthesis of the lipids within the liver? Absorption from the diet, de novo lipogenesis, cytoplasmic triglycerides can be hydrolyzed, and the liver also has a cellular uptake and metabolism of lipoproteins. Triglycerides are the main storage form of fat in the liver, and it is obtained by the esterification of glycerol with free fatty acids. Beta oxidation of the free fatty acids yields acetyl coenzyme that enters a Krebs cycle, and the surplus will get converted to ketones. Now, we all know about cholesterol. We like to measure our levels of cholesterol. We are very proud when our HDL is more than 50 and our triglycerides are, if they are low, and your VLDL is, your LDL is less than 130. So what are the functions of cholesterol in the body? Now, besides giving these biological figures that tells you that you won't have an MI or not have an MI, which is again a challenge so much by the cardiologist, cholesterol helps in membrane preservation. It is a precursor for steroid hormones. It is, of course, important in the formation of bile salts, lipoproteins, and cholesterol esters. When the liver is affected in chronic disease, as in cirrhosis, you'll find if you take a sample of blood from a patient with cirrhosis and send it for lipid assessment, you'll find the cholesterol is 50, triglycerides are 40, HDL may be low or it may be 30, 40. So this is just to say the synthetic function of the liver is not happening, and definitely synthesis of cholesterol is one of the functions of the liver. Now, I'm just moving to bile because I feel they're a little interrelated. Bile, you all know, is a substance produced by the liver, contains a mixture of bile acids, water, cholesterol, and bilirubin, and obtained from the breakdown of the red blood cells. Normally, cholesterol is broken by the enzyme 7-alpha hydroxylase to form 7-hydroxycholesterol to form the bile salts, cholic and chenodeoxycholic acid, which undergo conjugation with glycine and taurine to form the secondary bile acids, and this passes down into the intestine, where nearly 85% of these bile salts are reabsorbed either in the terminal ileum or in the colon and forms part of the enterohepatic circulation. Now, you all know that the bile that is produced comes in the biliary canaliculi, and then it is actually released in the intestine in the sphincter of Oddi. The functions of these bile salts is actually to emulsify the dietary lipids and permits their absorption. So this is by the formation of micelles, and along with this you have the formation of absorption of fat-soluble vitamins A, D, E, K. Now, the bile salts also bile also allows the excretion of lipophilic xenobiotics, cholesterol, and steroid hormones. Right. The bile salts, which are formed from cholesterol, have a regulation on cholesterol metabolism because they bind and they activate a receptor called FXR, which is the farnesoid X receptor. How does this control? This receptor decreases the transcription of the enzyme that converts cholesterol to bile acids. Therefore, if this enzyme is not allowed to regenerate, the breakdown of cholesterol to bile acids will be decreased, as can happen in liver failure. The next function of the liver is towards the synthesis of clotting factors. Now, for the PG to remember, all clotting factors are synthesized by the liver except factors 4, which is calcium, factor 8, which is the anti-hemophilic factor, and von Willebrand factor, which strictly does not come in the list of coagulation factors. They are secreted by the endothelium, right? So what does it take for blood to clot? All the clotting factors synthesized by the liver. And how do you assess a function of the liver? You use a prothrombin time, or the INR most commonly. And these are the factors that will be measured by doing the INR. Factor 7 activate the tissue factor, and factor 7. Factor 10, prothrombin and fibrinogen. That's factor 1 and 2 that will form a monomer, polymer, and then a clot. APTT refers to an extrinsic pathway. Now, I'm aware that today we are supposed to talk of coagulation as initiation, amplification, and propagation. However, the figures will still point to this cascade of factors, and therefore I'm using it. Right? APTT will look at the older extrinsic pathway, 12, 11, 9, and then the final common pathway. Right. The functions of the liver are such that in addition to synthesizing all the clotting factors stated, it also synthesizes naturally occurring anticoagulants, the deficiency of which leads to prothrombotic states. I'm having a lot of disturbance in the mic. If someone's mic is on, right. So deficiency of these leads to congenital hypercoagulable states, and you will find young people coming with recurrent mesenteric arterial thrombosis. So, and then they would need to undergo a small bowel transplant, or they have multiple surgeries. So, protein S inactivates factor 5A and factor 8A complexes along with activated protein C. Protein Z inactivates activated factor 10. Plasminogen activator inhibitor inhibits the action of streptokinase and urokinase in the inhibition of plasminogen to plasmin. Now, strangely, in liver disease, although you have a deficiency of three systems of platelets, of clotting factors, and the fibrinolytic pathway, these are the three pathways. You have low platelets in liver disease. You can have abnormal platelet function. There's a decrease in thrombopoietin and an increased production of nitric oxide. And how does a body compensate in chronic liver disease? There is an elevated level of von Willebrand factor that allows platelet aggregation, and a decrease in the level of ADAM-TS13, which is a metalloprotein that inhibits this conjugation. So the platelets are looked after. While you have low levels of all the coagulation factors, you have elevated levels of one coagulation factor and low levels of inhibitory factors, protein C and protein S. While you have low levels of antiplasmin and elevated levels of tissue plasminogen activator, which is a fibrinolytic, the substrate from which fibrinolysis takes off, which is plasminogen, is decreased. And therefore, this is called as a rebalanced coagulation in liver disease. So I won't bore you more with this anatomy and physiology. I'll just conclude by summarizing whatever I've said. The liver is a large organ receiving about 1/3 blood supply. The unique blood supply balances oxygen delivery during hypotension. Hepatocytes have the ability to regenerate by mitosis, and this paves the way for living donor donation. Ammonia is detoxified in the liver by the urea cycle. In liver failure, ammonia or glutamate can cross the blood-brain barrier, producing cerebral edema and may even lead to brain death. Lactate is metabolized by the liver to bicarbonate or oxidized to pyruvate that enters the citric acid cycle for energy production. Bile salts regulate the breakdown of cholesterol by the feedback mechanism. When you have obstructive jaundice, this failure to excrete the bile salts may result in the circulation of abnormal lipoproteins. I think one of them is called as lipoprotein X, which mediates several inflammatory mediators that contribute to the pathophysiology of the changes that occur in obstructive jaundice. Again, in clotting, the liver is the most important organ. All clotting factors, barring the ones I have mentioned, are synthesized, and you have a unique rebalancing in CLD. Thank you so much, and I'll be happy to take any questions, either probably now. Can anybody hear me? Am I audible?
Yes. Yeah, you are very good. It is very eloquent and clear presentation by Dr. Lakshmi. The experience shows there. Thank you very much for this excellent presentation, Dr. Lakshmi.
Thank you. Should I, if there are no questions?
I am looking for questions. I just also look into this, our YouTube, if there are any questions. So far, there are no questions. So, thank you so much for this wonderful presentation, Dr. Lakshmi. I think.
Thank you, Dr. Sripada.
Thank you.
If there are questions, you could always put it on WhatsApp, so I can answer to them personally.
Yeah. So I request all the audience to put the question directly to Dr. Lakshmi so that you can get answers. We'll move to the next session.
Thank you, Dr. Sripada.
Thank you so much. Thank you. Next session is about liver transplant. A patient with terminally liver failure coming for liver transplant by Dr. Gurudat and Dr. Shivani Kamath. The students are Dr. Gauri Pratyusha and Dr. Deepa Anna Thomas from KS Medical Academy. Dr. Lakshmi, I request you to make me as host. I also recognize the presence of Dr. Anil from JSS, Dr. Bindu George.
Dr. Sripada, I'm putting end and it says leave meeting or end meeting for all. Leave meeting.
Yeah, can you please
assign
make
and leave.
me a host?
It says assign and leave. I made you the host,
Okay, okay. Thank you so much.
but it's not
I think now, Dr. Shripad, you are the host.
Yes, ma'am. Yes, sir.
You can share the
Yes, sir.
you can share the screen, I think.
Okay. Okay. I am sharing the screen. Huh? Yeah, can you see?
Yeah.
It's coming. Thank you, but screen is not moving. Yeah, can you see the slides moving?
Yeah.
Okay. Okay, over to Dr. Gurudat and Dr. Shivani about case presentation. I invite Dr. Gauri Pratyusha and Dr. Deepa to join the case discussion.
Thank you, Dr. Shripad, and thank you, Shema, and all the staff members of KS Medical College. And you're doing a wonderful work of having some PG teaching every month, once in a month. So thank you very much for inviting me to moderate this particular session along with Dr. Shivani from Bombay. So we will be discussing about a case presentation actually regarding the chronic liver disease patient being posted for liver transplant surgery. Of course, many of the institutions will not be conducting this liver transplant surgery, and many of the students may not have been exposed to liver transplant surgery. But unfortunately, many times what happens is when these students take up the exams, of course, in theory, they'll invariably there will be a question on liver transplant surgery and anesthesia. But many times, even in practicals, they'll definitely get a chronic liver disease patient, and especially it can be even an end-stage liver disease patient. And the students will be asked about how they are going to anesthetize this patient for non-hepatic surgery and also for liver transplant surgery. So today we'll be discussing about this chronic liver disease patient being posted for liver transplant surgery. Of course, we have an expert on this liver transplant anesthetist from Bombay, that is Dr. Shivani is there. And what I'm thinking is till the patient is taken for the anesthesia and transplant surgery, I'll be conducting the discussion, and afterwards Dr. Shivani will take over from me, because my exposure to liver transplant surgery is only one liver transplant surgery that we had in our JSS Medical College Hospital a few days back. So that's why I'm not very much experienced in this. So anyway, the other things, definitely I can ask a lot of questions, and also I can discuss very well regarding the chronic liver disease patient. So we have with us today Dr. Pratyusha and Dr. Deepa from KS Medical College. So they'll be presenting this particular case of CLD. So I request either Dr. Pratyusha or Deepa to go ahead and then present the particular case. Or what they can do is one can present the history part and the other can present the examination part. So over to Pratyusha and Deepa.
Good evening, sir and ma'am. This is with Deepa and Pratyusha. We'll be presenting a case on chronic liver disease.
Can I see who is Pratyusha and who is Deepa? Because so can you just introduce yourself, Pratyusha and Deepa? I am not able to see your faces. Just introduce yourself. Hello.
Hello, sir.
Yeah. Can you introduce yourself?
Sir, you see us, sir?
Yeah, I am able to see you.
My name is I'm Deepa, sir. And I'm Pratyusha, sir.
So again, your pictures are not there. Video is not there.
Video is there. Video is there.
Yeah, now it has come.
I'm Deepa.
So, oh, you are Deepa and the other girl is Pratyusha. Fine. Okay. One of you start presenting the history. Right, Deepa.
This is a case presentation of chronic liver disease. So, a 60-year
Can you see the screen, sir?
Yeah. It's very clear.
A 60-year-old male, Mr. Krishnappa from Mangalore, he was a driver by occupation. He came to us with chief complaints of yellowish discoloration of the skin and sclera since 15 days, abdominal distension since 7 days. History of presenting illness. The patient is a known alcoholic since the past 20 years. Patient was apparently normal 15 days ago when he presented with a yellowish discoloration of the skin and sclera, which was gradually progressive in nature. Abdominal distension since 7 days, which was gradual in onset and progressive in nature. There was no history of any pain abdomen. There was no history of any altered sensorium, increased lethargy, inappropriate behavior. There was no history of passing blood in stools or any clay-colored stools. There was no history of pedal edema, no history of loss of weight. There was no history of fever, infections, exposure to any toxic substances. There was no history of decreased urine output, breathing difficulty, or bleeding from the gums or any orifices. Coming to the past history, there was a known case of systemic hypertension since 3 years. There was no known history of type 2 diabetes, bronchial asthma, epilepsy, tuberculosis, or any thyroid disorders. There was no history of previous blood transfusions, no history of any drug intake other than his present treatment history, and no drug allergies, and no past surgical history. Presently, the patient was taking amlodipine 5 milligram OD. He was also on beta blockers, propranolol 20 milligram BD. He was on loop diuretics and potassium sparing diuretics, furosemide of 20 milligram OD and spironolactone 25 milligrams since the past 1 month. Coming to family history, there was no history of similar illnesses in the family. Personal history, he was an alcoholic. He used to take brandy around 180 ml daily for the past 20 years. He was also a smoker for 20 years with pack years of 10. He presented with decreased appetite, mixed diet, and disturbed sleep. He also had a normal bowel and bladder habits. Coming to general physical examination, patient was moderately built and nourished, weighing around 70 kg with height of 164 centimeters, BMI around 26 kg per meter square. To head-to-toe examination, patient presented with moderate itches, grade 2, bilateral pedal edema. Head-to-toe examination showed brittle hair, spider navy present over the back, gynecomastia, and testicular atrophy noted. There were no scratch marks over the abdomen or dilated veins over the abdomen. Coming to vitals, patient had 76 beats per minute regular rhythm measured on right upper limb. Blood pressure measured around 170 systolic bar 50 diastolic mmHg, and saturation 98% in sitting position and 98% in supine position. Coming to respiratory rate, 14 cycles per minute, and patient was afebrile. Systemic examination, per abdominal examination on inspection, abdomen was distended equally, all quadrants were moving with respiration. Umbilicus was center and everted. There were no scars, striae, or visible pulsation, no skin discoloration or visible peristalsis. Coming to palpation, superficial palpation, there was no guarding or rigidity, or there was no rebound tenderness. Deep palpation could not be assessed adequately. On percussion, flank dullness present, fluid thrill was present, and liver span was 9 centimeters. On auscultation, bowel sounds were heard, and there was no venous hum or a bruit heard. Other systemic examination, Cardiovascular system S1, S2 heard, though no other murmurs heard. Respiratory system normal vesicular breath sounds heard, no added sounds. On central nervous system examination, patient was conscious, oriented, higher mental functions were intact, no motor or sensory deficit, cranial nerves were intact. From the history and the examination part, we come to a conclusion of diagnosis with chronic alcoholic liver disease with portal hypertension.
Okay, thank you, Deepa and Pratyusha. I think you can stop sharing the screen. We can start discussing about this particular case.
Just completely.
So, okay. One thing I just wanted to tell you regarding your case presentation is that we know that here you are trying to tell that this all the problems for this particular patient is because of his alcohol intake, isn't it? Because we know that usually the most common cause of end-stage liver disease or chronic liver disease in India is alcoholic liver disease. And the other things, yes, especially non-alcoholic steatohepatitis and infections. So these three are the most common causes. But when you are presenting it, because you know that this patient is in chronic, he's got a chronic liver disease. So bring this history of alcoholism in the history of presenting illness itself. So try to talk more about this history of alcohol in your history of presenting illness. So another very important thing is that you have quantified the amount of alcohol he is taking. Like pack years, you also have said that patient is taking about 180 ml of brandy every day for the past, say, I think 20 years. That's what you said. Now, why did you quantify this amount of alcohol he is taking? Deepa, can you just tell? What is the requirement of telling about 180 ml of brandy every day for the past 20 years? Is it significant enough to produce chronic liver disease? Deepa, can you hear me? Hello? Hello, Deepa and Pratyusha? So we have lost both Deepa and Pratyusha. Hello?
Sir, I think you have lost them, sir.
Yeah,
Process
some of
it.
I'm not able to. Yeah, I'm not able to see them or hear them.
Absolutely, sir. I think we should call Sripak sir and find out.
I'll call Pratyusha only and then let us see. Pratyusha, I'm not able to contact you. So how do we go ahead? Yeah, yeah. Okay, okay. Right. Anyway, let me talk to the other postgraduate students. Probably they may be hearing me. So this one thing is very important, that you can definitely quantify the amount of alcohol the patient takes, like the pack years or even smoking index. So if a patient takes about 80 grams of alcohol every day for a minimum period of 8 years, there is a high risk of this patient developing yeah, Pratyusha and Deepa, we got you back. So I was asking you about 180 ml of brandy the patient is taking every day. So why did you quantify this? What do you mean by 180 ml of brandy? So for that, you have to know what is the percentage of alcohol in brandy. That is very important. Actually, whenever you are taking history in the exam, so you are supposed to tell what kind of a particular brand of the alcohol he is taking, whether it is whiskey, brandy, or any other rum, or even arak. So all these contain what is the percentage of alcohol in these alcohol drinks. How much percentage of alcohol they'll contain? Because I just said that minimum of 80 grams of alcohol every day, if a patient takes for minimum of 8 years, he is likely to develop chronic liver disease. So any idea about what is the percentage? Because you specifically said brandy.
Around
No, all these, contain, because it is always better to know. Usually the beer contains about 7%, and some of the beers also contain 14%, like Knockout beer, Kalyani, Khajuraho. So it is always better to know about these brands so that you know what is you can calculate the amount of alcohol intake by the patient. So all these, whiskey, rum, and then brandy, all of them contain nearly 45 to 50%. So 50% means 50 grams per every 100 ml. So your patient is taking about 180 ml of brandy every day. So naturally, he is taking nearly more than 80 grams of alcohol, and even 8 years is sufficient. Now he is on this intake of alcohol for the past 20 years. So that means definitely he is a candidate for developing chronic liver disease because of alcoholic hepatitis. So another thing I just noticed is that you have written about jaundice.
Yes, sir.
So that is in the history again you have written about. So patient is not passing clay-colored stools. So jaundice and clay-colored stools, why, how they are related? Can you just tell about it?
That would have indicated some obstructive jaundice that is probably suggestive of gallstones. Gallstone.
Yeah, very good. Because that is another very important thing. When you say in the history about jaundice, you'll have to talk about what kind of jaundice is this, whether it is pre-hepatic jaundice, hepatic jaundice, or the post-hepatic jaundice. So post-hepatic is also called as a surgical jaundice. And usually the one important history which can differentiate these two, hepatic and post-hepatic, is the patient passing clay-colored stools. Why clay-colored stools? In the color of the stools being clay or almost nearly white. Now, why that in obstructive jaundice?
Stercobilinogen is not formed, sir, because bilirubin metabolism is compromised.
Yeah, because bile is not being secreted into the intestines. So because of the obstruction, naturally there is no pigment, both urobilinogen and stercobilinogen in the feces. So that's how. So that's very important. Another very important history you should always take is since how long the jaundice is present. Suppose the jaundice is present since childhood. So what do you think? Now the patient is 60 years. Yeah, it can be. Yeah, it can be congenital hemolytic anemias. So that is another history you can always talk about. And another thing about the jaundice, examination of the jaundice. So you can even say whether it is mild, moderate, and severe as far as during the examination itself. So if the yellowish discoloration is confined only to sclera and not to the mucous membrane and the skin, you can say it's a mild form. And mild form is usually either majority of the times it can be in hemolytic jaundice. And if it also involves the mucous membranes, then it can be moderately severe, and that can be in hepatic jaundice. And in obstructive jaundice, it will be very severe. So that is even the skin color will be quite deep yellow, and the eyes can be orange, nearly yellowish orange. So that is another thing. So one more thing I saw in your presentation was that you had recorded the pulse oximetry in lying down and sitting posture. So, okay. So Deepa, can you just tell why did you record in two positions?
Our patient has ascites, sir. He's a known, he has ascites. So
Okay.
when the patient that he moves his position from a recumbent position to the sitting position, sir, in patients with cirrhosis, they may develop what is called platypnea or orthodoxia.
Very good, very good.
Reduced functional residual capacity. And
No. It is nothing to do with the FRC. FRC will be better in the sitting posture, isn't it?
Better in the
So
sitting
because
posture,
the
yeah.
lower zone is the predominant, and because of portal venous hypertension, there will be splanchnic and there will be decreased gas exchange at the alveolar bed.
There'll be
So
intra-
as in sitting position, the lower zone is more predominant. That's when the gas exchange further decreases and causes desaturation more in sitting compared to supine.
there'll be
Yeah.
intravascular
Yeah, this is another important thing you should always remember about chronic liver disease. This is an exam question, orthodeoxia and platypnea. Because normally patients with respiratory disease or cardiac disease will have orthopnea. That means when they lie down, they have more discomfortable as far as their breathing is concerned. But here it can be opposite. In the lying down posture, they can have more, relaxed thing, like they can breathe better. And in sitting posture, they may have more desaturation. So if this is there, what do you think the patient has?
hepatopulmonary syndrome.
Hepatopulmonary syndrome, isn't it? So suppose if I take an ABG of this patient and finds that he is breathing room air and his PaO2 is around 50 millimeters of mercury. So what do you think this patient has? What phase of hepatopulmonary syndrome he has?
Very severe, sir.
Because it is classified as mild, moderate, severe, and very severe.
Based on PaO2.
Yeah. One is PaO2 and another thing is AA, partial pressure gradient of oxygen, isn't it? So what should be the AA PaO2 for diagnosing hepatopulmonary syndrome? How much it should be?
More than 15 millimeters of mercury.
Yeah, more than 15 millimeters. And based on ABG, how do you say that the patient has got mild, moderate, severe, and very severe? What should be the PaO2 on breathing room air?
The PaO2 is less than 80, sir, 80 millimeters of mercury with an alveolar arterial gradient of oxygen of more than 15 millimeters of mercury. It is said to be mild, sir.
Okay, mild is above 80.
Above 80, sorry, above 80.
Above 80 PaO2. Moderately severe is? 60 to 80.
80. Then 50.
And 50 to 60 is?
50.
Yeah, severe, and very severe is anything less than 50 millimeters of mercury. So that is another very important thing. So that if you have a ABG, you can definitely know what is the A gradient, whether the patient has got pulmonary syndrome. That is one thing, and even you can know what is the severity of hepatopulmonary syndrome. So it's mainly because of the dilatation of the capillaries. All over the body, there is vascular dilatation. So that's how, there will be dilatation of the capillaries also. Here, there will be, the distance between the alveoli, the oxygen in the alveoli to the capillary, the RBCs in the capillary will increase. So especially the RBCs passing through the middle of the capillaries may not be getting enough of oxygen. So this is one of the causes for hepatopulmonary syndrome and A gradient increase. The another thing is the intrapulmonary shunts, isn't it? So, but if it is only due to the distance, because the capillary diameter can increase up to 500 micrometers. So if you provide supplemental oxygen, it will improve. But if it is more due to, intrapulmonary shunts, even if you provide oxygen, so that will not help much. So that's how, hepatopulmonary syndrome. Another problem is the portopulmonary hypertension also. This is maybe about 5% or 10% of the patients with CLD, they can also have. So how do you diagnose this portopulmonary hypertension?
It's done by right atrial catheterization, sir.
Or even echocardiography? If you know MPAP, mean pulmonary arterial pressure.
Pressure more than 25
millimeters.
mmHg at rest and more than 30 mmHg in strenuous or exercise conditions.
Provided pulmonary capillary wedge pressure supposed to be, of course, for that you require a pulmonary arterial catheter. It should be less than 15 millimeters of mercury. So that is the thing to know about, and especially if the mean pulmonary arterial pressure is more than 50 millimeters of mercury, 50, it is a severe form of portopulmonary hypertension. Many times it may be one of the contraindication, maybe for liver transplant surgery. Okay, and another thing you said is about the pulse and then the blood pressure. So when you are talking about the pulse, hyperdynamic circulation, there will be wide pulse pressure that you have to talk about the volume and the pressure being high. So that is one thing. And the pressures, arterial pressures, you showed that the pulse pressure is quite wide, more than 60 millimeters of mercury. So that is another very important thing. So Deepa, why there can be an hyperdynamic circulation with these patients?
The systolic blood pressure increases because of the decrease in systemic vascular resistance. This is
Now, why there is a decrease in systemic vascular resistance?
will be in vasodilatation, sir. There will be
Why vasodilatation again?
because there will be release of vasodilators, the chemical vasodilators, that is your nitric oxide, prostaglandins, they'll be released. And
Okay.
there will be and there'll be vasodilatation, more pooling in the splanchnic circulation.
And another thing you should always realize that majority of these vasodilators are, metabolized in the liver itself afterwards. So because the liver is failing, it is not metabolizing these vasodilators, they are released into the circulation. That's how, there is a generalized vasodilatation. So that is the one thing. And because of this generalized vasodilatation, there can be a problem to the kidneys as well. Now, Pratyusha, why there can be a hepatorenal syndrome wherein there can be a renal failure also in these patients or raised serum creatinine?
So as splanchnic circulation, the blood going, there is a blood, but it is going to the splanchnic circulation, spleen and the other part. So there is a decreased blood supply to the kidney, causing ischemic damage, acute kidney injury.
The renin-angiotensin.
And renin-angiotensin tries to retain the fluid along with the electrolytes for the worsening the syndrome.
What kind of renal failure? Is it pre-renal or renal or post-renal failure in these patients? This hepatorenal syndrome, is it pre-renal, renal or post-renal?
Pre-renal.
Yeah, pre-renal, very good. So how do you know it is pre-renal or renal? Suppose the patient has developed oliguria, in spite of you giving all these spironolactone, furosemide, all those things, and his serum creatinine is rising. How do you know that it is pre-renal or renal?
So once the diuretics are stopped and the circulating volume has been normal, if they respond to it, creat decreases, then it is
Now, by urine examination, you can find out. Suppose I know that urinary sodium is this much, urinary creatinine is this much. So any particular test is there to know that whether it is pre-renal or renal?
urinary osmolarity.
Okay, urinary osmolarity, what happens in pre-renal and in renal? So urinary osmolarity will be very high in pre-renal because the concentrating ability of the kidney is preserved. So it can be as high as more than 300 to 400 milliosmoles per liter. But in case of renal failure, that is because of acute tubular necrosis, the osmolar, because concentrating ability of the kidney is not there, it can be as low as 100 milliosmoles per liter. So that is one of the things. Then again, urinary sodium, the amount of sodium. So, here the sodium excretion is very much decreased in pre-renal because the body tries to conserve as much as water and sodium. So that is the reason the amount of sodium going through the urine will be less than 10 millimoles per liter. Whereas in renal, the amount of sodium excretion can be above 20 millimoles per liter because it cannot retain sodium whenever there is renal failure as a result of acute tubular necrosis. So that is another very important thing. And the third thing is fractional sodium excretion also, you can definitely do it. So fractional sodium excretion, if it is less than 1%, it is pre-renal, and if it is more than 2%, it can be renal. So this is very important for us to know exactly what is the etiology, because if the etiology is pre-renal, so definitely improving the circulation to the kidneys will definitely help in managing this. So that is okay. Now the patient is being posted for liver transplant surgery. Let us say that what are the investigations you would like to do for this patient before taking up, and what are the preparations you would like to do before taking up? So what investigations you would like to do?
So coming to it can be classified as non-specific or specific investigations required for the surgery, sir. Non-specific would include the complete hemogram and
Okay. Hemoglobin, you want to get it done?
yes, sir.
Yeah. Why hemoglobin? Any problem can be there as far as hemoglobin in these patients?
Suspecting anemia, sir, because there could
Yeah,
be
anemia.
bleeding manifestations, sir.
And
Not only bleeding, nutritional deficiencies also.
Yes, sir.
And there can be, the spleen
Also,
is also so huge, sequestration of RBCs in the spleen, and definitely the reduction in the life of these RBCs also can be there. Another very important thing is to calculate the MABL, maximum allowable blood loss, and especially if the patient is being posted for a non-hepatic surgery. Of course, hepatic surgery, there'll be, then liver transplant surgery, there can be a lot of bleeding, and you definitely arrange for a lot of blood products, because there can be a chance of the patient may require quite an amount of blood products to be administered to the patient intraoperatively. So that is one thing. And second thing, you said that the leukocyte count, can it be increased? Can it, because of something?
if there is any infection, we can control the infection or prevent. If it is posting for a transplant, as we will put the patient on immunosuppressant later, so it can aggravate the infection as such, sir.
So because majority of them are immunosuppressed, one problem. Second thing is spontaneous bacterial peritonitis is another thing that can occur. So that is the reason it is always better to get the thing. And these patients may also require prophylactic antibiotic therapy. So, okay, what other investigation? Urine, just now we discussed about urine, isn't it? So urinary sodium, urinary creatinine, or fractional excretion of sodium. And also if there are epithelial cells, epithelial casts, so it can be acute tubular necrosis as well. Okay, further investigations?
renal function tests, sir, we'll do. We'll also do liver function tests. We'll take a bit ECG we'll be taking. We'll also take a chest X-ray.
So ECG, what changes you would like to find in ECG?
So tachycardia, sir, bradycardia, any arrhythmias, any QT prolongation.
Okay, these patients also may have a prolonged QT. That is another very important thing. So definitely if the patient has got a prolonged QT, they are prone for what kind of dysrhythmia intraoperatively? Dorsitis depointis, isn't it? Polymorphic ventricular tachycardia is a problem. That too, if you are using certain drugs which further prolong the QT interval, like ondansetron. So that is always a problem. Many of our volatile anesthetic agents also can produce prolonged QT interval. Along with already prolonged QT, the patient is definitely prone for dysrhythmias. And this patient is 60-year-old, chances of coronary artery disease is also there. He is a smoker also. So highly likely he may have coronary artery disease. So definitely you can find out the patient also has coronary artery disease. Okay. So chest X-ray would like to have?
Yes, sir.
Why do you want to have a chest X-ray in the patient with chronic liver disease?
We have to
Anything
do
you would like to find out?
Yeah,
Pleural effusion.
As in this history is a smoker, so need to predict the post-operative pulmonary complication also after the surgery. So.
No, but in any smoker, you can definitely find an emphysematous chest X-ray just for knowing whether the patient has got any emphysema or emphysematous chest. You need not have to take an X-ray, but smokers definitely, because they are prone for two things. One is repeated respiratory infections, pneumonia. So a patient with pneumonia, you cannot accept for any liver transplant surgery. So that is one thing. Second thing is the malignancies of the lungs also is very common. So just to rule out these things, definitely you can take a chest X-ray. Plus, we're talking about the hydrothorax these patients can have. So that by examination itself, definitely you can make out whether there is any hydrothorax is there or not. Okay, chest X-ray is fine. So then echocardiography, already we discussed few things about echocardiography.
Pulmonary artery.
Definitely, yeah, that is there. And also to contrast echocardiography, I think Dr. Shivani would be better in talking about the contrast echocardiography. I think she will be talking about that. So that is also another very important thing. And also, because I just told you about coronary artery disease is also quite common in these patients, male patients, smokers. So again, echocardiography is very important. And again, coming to the electrolytes, because this patient is already on diuretics. He is on 2 diuretics, furosemide and spironolactone. So any problems of electrolytes in these patients?
So hyponatremia.
Hyponatremia.
Hyponatremia. As such, the patients with CLD can have hyponatremia, isn't it? Why hyponatremia in a CLD patient?
Because they will have
It is
sodium and water
hypovolemic
retention.
hyponatremia, sir.
A dilutional hyponatremia, isn't it? So dilutional hyponatremia is very common. Plus, he is on diuretics. So naturally, hypokalemia, hyponatremia, both can be there. So serum electrolytes is another very important investigations you would like to have. And the specific liver function test. So what specific liver function test you would like to do?
Liver elastography to rule
First
out
is albumin, isn't it? Basic thing about albumin. So will there be any hypoalbuminemia in these patients?
Globulin usually is normal, sir. Albumin will be decreased.
Why albumin will be decreased?
Protein metabolism synthesis is in the liver. So if the liver is dysfunction, then albumin will be less. This decreases.
Yeah, albumin is basically synthesized from the liver, isn't it? Any end-stage liver disease or chronic liver disease, the albumin levels will be low. And why should you know that hypoalbuminemia is there? What is the importance of decreased albumin levels for you as anesthesiologist?
Number one, it decreases the oncotic pressure, thereby causing it also binds to bilirubin and brings it into the liver. So unconjugated bilirubinemia will be there.
So protein-bound drugs are
Very good, very good. So it is basically because majority of our anesthetic drugs are bound to albumin. So because of that, you have to be careful in how much you give these drugs, because there can be increased concentration of the free drug. So that is why albumin is important. And what is the half-life of endogenous albumin? This albumin that is synthesized in the liver, it's an endogenous albumin, isn't it? So what is the half-life? How long it can persist in the plasma? And what is its importance? So the half-life of this albumin is 21 days. So albumin is very important to differentiate acute liver failure from chronic liver disease or chronic liver failure. So in acute liver failure, the albumin levels may still be normal, because it will take about 21 days for albumin levels to fall. So that's how, very important to differentiate between acute liver problem and the chronic liver diseases. Okay, the other thing is about bilirubin. Liver function test you are talking about. So bilirubin is important. Again, the amount of bilirubin, it will be very high in obstructive jaundice, as I was talking to you about the mild, moderate, and severe jaundice also. And it can be moderately increased in, end-stage liver disease. And also it is very important, both albumin and bilirubin for, stratification of these patients. Again, child Turcotte-Cox classification, we will come to that. And, further is enzyme studies, AST, ALT. Yeah, okay. So anything we want to contribute regarding this AST, ALT in these patients?
ALT is the more specific to liver damage, sir.
Which one? Which one is more specific?
ALT, sir.
ALT is more, or SGPT. The old name is SGPT. Okay.
AST can be seen in myocarditis or cardiac ischemia mainly.
Okay.
So mainly, which is important for us is AST-ALT ratio, sir, which is more than 2 indicates an alcoholic liver disease, sir.
Very good, very good. So it can be less than 1 in case of acute hepatitis, due to other, especially the infective origins, and even massive liver necrosis, all those things. The ALT levels will be much, much higher than the AST, but in alcoholic liver disease, AST levels will be higher than the ALT. So that is there. And the other enzymes like GGT, will it be increased in case of alcoholic liver disease?
Usually normal.
Yeah, it is specific to alcoholic liver disease. Gamma glutamyl transpeptidase or transferase, it can be increased in alcoholic liver disease. Also, it will be increased in obstructive jaundice. So again, the alkaline phosphatase, DGT and 5' nucleotidase, they are very specific for obstructive jaundice. Okay, so these are some of the investigations definitely you can do for these patients before taking up, and coagulation profile. That is the most important thing. So what happens to INR?
And increases.
Yeah, INR is increased because already Dr. Lakshmi Kumar was talking about all the coagulation factors except coagulation factor 4, that is calcium, and factor 8 are not synthesized in the liver. So though the vitamin K is again required for even if the conversion of procoagulants into active coagulation factors by gamma carboxylation. So when vitamin K will help in these patients? In which kind of jaundice, if the INR is prolonged, vitamin K supplementation will help, and in CLD, will it help or not?
In prehepatic.
Prehepatic INR will not be prolonged. It is nothing to do with the liver. And only in obstructive jaundice, because vitamin K require bile salts for absorption. So then because bile salts are not there in the intestines, it's a fat soluble vitamin, so it will not be absorbed. So why? Because of the lack of vitamin K, so procoagulants are not converted to coagulation, active coagulation factors. So that's how parenteral vitamin K will help. But in chronic liver disease, it may not help much, isn't it? So then you have to prepare these patients by probably by keeping ready fresh frozen plasma, or even you may have to give before taking up these patients, isn't it? So coagulation profile is very important. Again, intraoperatively also you'll have to do this coagulation profile, and also you were talking about thromboelastography and all. So with this, I would like I request Dr. Shivani to take over and proceed with the case discussion.
Thank you, sir. Actually, I also felt like a student listening to all of that. All right. Now, this.
So usually I'll discuss this liver for about 3 days for my students.
Right.
So with a very short time, 20-25 minutes, very difficult to concise the whole thing and then discuss. So you also know how big is this topic. Anyway, madam, you just go ahead and then proceed with the discussion. Yeah.
So now let's talk about this patient being posted for a liver transplant. Now you need to understand that there are two kinds of transplants that we do. One is an absolutely planned living donor transplant where, everything is ready, everything is pre-planned. The other is when, you have a brain dead donor, which you're getting from somewhere. And this happens usually in the middle of a night in an emergency. So the recipient, when he presents in this situation, is different in both situations, because when it is a brain dead donor, he is not at his best health. You are calling him in the middle of the night. He may have an infection. He may have other insults to his system when you call him for this transplant. So at that point of time, when he comes to the hospital, you have to send all your D-1 investigations, and you have to assess whether this patient is ready to take his liver. We are ready to give it, but is his system ready to take it? Whether he has infections, there are other challenges in his system. Is his ascites fluid drained? Is he cardiac-wise stable? So this is how you need to assess it. So all sorts of D-1 investigations have to be run through, whether it is an entire blood profile, your echo, X-rays, all sorts of scans. All right. If this patient is posted for an elective a living donor transplant, where somebody from his family comes forward and their liver is matched, as we call it, where the GRWR matches. What is GRWR? It is graft versus the recipient weight ratio, in which you are leaving enough amount of liver for the donor, as well as removing enough for it to be enough for the recipient's weight. Either of them falling short of liver makes this entire exercise futile. So we run the patient through a battery of tests. We do all the liver volumes, volumetries, and then we decide whether the donor and the recipient matches. So in this case, suppose he has a son who's ready to donate a liver, and we have planned the procedure. Obviously, the donor in a liver transplant program is very, very important. One needs to understand in any living donor, in any transplant program, the donor is a very important part, because he is a normal ASA1 human being coming forward to do a very noble cause. All right. So he has to be safe and sound till the end of discharge. Anyways, so the son comes forward and he undergoes a hepatectomy for his father. Previously, when we would do transplants, we would induce the donor and recipient together. Nowadays, what we do is, if there is any amount of doubt before the recipient is induced, the donor is induced, opened and seen, or laparoscopically the liver is seen to assess the quality of the liver before we induce the recipient. Do you understand? So that in spite of taking biopsies, bilobar biopsies from the donor, if still there is a doubt whether the quality of the donor liver is good or not, then we take the donor in, we do a laparoscopic assessment, and if yes, we then wheel in the recipient, right? So now you're going to wheel in this gentleman for the transplant. What are the things that you're going to do? Okay, he's, I don't know, what was his weight in your
72
20
kg.
kg.
So 72, according to me, is probably his ascitic volume, because these patients are very, very frail, fragile, you know. So you wheel him in, they'll generally be skin and bones, yellow with skin and bones with a huge tummy. So they wheel in, you wheel him in, and what is the first thing that you're going to do?
We'll attach all the monitors.
First thing you need to do is make sure he's warm. Once these patients start getting cold, there is no turning back. So we need a heating mattress which has to be on before he wheels in. OT has to be comfortable. Warming bear hugger has to be on. A bear hugger is a big blanket with a blower. So that has to be there to keep him comfortable, because once the patient is induced and opened and his temperatures start dropping, it is it's a battle by itself to keep the temperatures normal. All right, because hypothermia is another cascade which you're going to struggle with, whether it is acidosis or coagulopathy, you know. So now this patient is taken on the table and we attach the basic monitors, right? So we attach our ECG, our NIBP, and
saturation. Temperature, no, ETC.
Take a baseline saturation before we start pre-oxygenating. In the meanwhile, if this patient is hemodynamically unstable, if you're not sure, then we take an awake arterial line under local. All right. Now these patients are coagulopathic and they come with low platelets.
Yes,
so if the platelet is less than 50 and we have sent a baseline text, so as soon as you put in an outline, we send a baseline thromboelastography. If our tech tells us that this patient is going to bleed or he needs platelets, before we induce or while induction, we start running either FFP, cryo, or platelet according to our thromboelastogram. So we are all ready for our lines, and the patient is optimized when we try putting our wide bore cannulas in the neck, in our wide veins. All right. Now you want to induce this patient. What are you scared of? What are you looking forward to?
Hypotension, or one will assume this patient has mostly a full stomach, either because of their ascites or because they've had their NPO is not adequate. And also the time to desaturation will be very less. Their functional residual capacity will be less. So these will be our primary concerns. So mostly we'll do rapid sequence induction.
Okay. So what are the drugs? So there are protocols different places follow. We give thiopentone, fentanyl, thiopentone, and rocuronium is what we use. And we intubate these patients. These patients, while intubation, also bleed. When you do a laryngoscopy, it has to be a gentle and smooth laryngoscopy, and you intubate. I think amongst all these lines, the most difficult line to put is the Riles tube. Because of the varices that these patients have, it can be a suicidal thing. When if the Riles tube damages any of the varices that are present, then there is no looking back. Because any amount of resuscitation after that is going to not help very much, unless the other liver comes in and the physiology becomes normal. So then we put in the Riles, we intubate this patient, we put in the Riles tube. Then we look on to putting the central lines, right? So in this point of situation, one needs to put this under an ultrasound guidance. You cannot put central lines under anatomical landmarks. because they don't give you too much of, it's just one prick, because after positioning, when you hit your vein, it starts forming, it starts oozing and it starts forming a hematoma. That vein then collapses. So there is not much window that you get between putting your needle in and your guide wire and putting your central line inside. Now, previously we used to get an advanced venous access. Now that is not available. That has, the production has been stopped. So now we use Mahurkar catheters. So in the same IJV, we put 2 guide wires, and we using the Seldinger technique, we put either quadrilumen or a triple lumen central line and a Mahurkar in the same IJV. All right. So it is a very simple concept that the central lines are used for the inotropes, and the Mahurkar is used for your fluid access, rapid fluids. It is also sometimes used, we have used it in case the patient has a renal shutdown for whatever reason. It is used as it's used for CRRT, replacement, renal replacement. Yes. So that's when we use the Mahurkar. So these are our life savior lines. We also can put a peripheral large bore and get it in case we need it. So this is the basic induction of our liver transplant patient. Other than the central line, the arterial line, we also use a cardiac output monitor. And this cardiac output monitor that we know, there are many types of cardiac output monitors that we use, which use different formulas. Some of them are, you would have heard of them, PICO, LIDCO. The commonest one and simplest one used is the flow track, which is used widely, in which one of it is connected to the art line and the other is connected to the central line, and we enter the height, the weight of the patient, the sex, and the age. And then there is a formula with which we get different variables of the patient, whether it is cardiac output, or SVR, SVV, that is stroke volume variations, vascular resistance. All of these numbers are on a screen. Now, one has to understand that we need to zero this before we start using, and we don't take these numbers as absolute. Because once the patient is opened up and there's a lot of hemodynamic instability, these numbers cannot be relied on. What we learn from this is the way it flows, the pattern of it is what we follow. Okay. Now I will just run through, I will just talk on liver transplant, since I don't think you all would have seen a liver transplant, right? So we stress a lot on consent, because this patient needs to understand that what he's undergoing is not a normal surgery. It's a high risk consent. And before the transplant is done, there's a committee, a government committee that sits and gives permission to the institute to, do the transplant after certain clearances. Now, antibiotics play a very, very major role in these surgeries, because these patients are admitted multiple times before they undergo transplant. So if we have already escalated them to meropenem or any of the higher antibiotics, it's very difficult for us to take 2 steps back. So we need to know the entire course of their illness and what all antibiotics have been used for it. So we know where to hit and when to hit hard. All right. The other thing is the theater preparation. Like I told you, the mattress has to be warm at 42. We have to have all fluid warming devices on. There has to be forced air warming blankets, like an upper body warmer. We need to have our rapid infusion sets ready in case of a major bleed. Pressure bags in case we want to give rapid fluids. The blood bank has to be alerted. And before we take the patient in, we generally keep 10 PRPCs, 10 FFPs, and 2 single donor platelets. And all these products are irradiated or leukodepleted, because we don't want to insult the body more with any amount of antigens. Right? Because these patients are already getting a liver from outside and they are going to be immunosuppressed post-surgery. All right. Syringe pumps. So the Indian scenario of a transplant OT looks like a rocket launching. That is one of the things that fascinated me when I joined liver transplant. It looked like we're launching a rocket, though in the UK, they don't make it such a big deal. And then we have the drugs that we use. So basic are once we have induced this patient with fentanyl, rocuronium, and thiopentone or propofol or etomidate, whatever the institute wants, we have to have basic infusions ready when we induce these patients, because these patients could crash on induction. So even the placement of these infusions is something that is a protocol. So the upper part is always the inotropes. Okay, the hand level is where you want to play with the infusions that you want to play with, which is your calcium, your bicarb. All right, if you want to give any sort of bolus. And the ones down are your infusions that go on throughout surgery. Which are the infusions that we go on throughout surgery? That is the N-acetylcysteine, okay, which is a free radical scavenger. Then the other one is tranexamic acid. That this is given as a fiber to exactly, it helps in fibrinolysis. Then the muscle relaxant. All these drugs which go on throughout surgery are the ones that are placed down, because it's very meticulously planned procedure. So the other things which are loaded and kept ready are, I talk about the inotropes. So we have NORAD, we have frenin, and adrenaline is one thing that is always kept, because you never know when you need it. Okay, then the middle part is the calcium and bicarb. These are the two very important infusions in transplant. We also sometimes do use potassium as per our ABG dictates. The lower ones are tranexamic acid, N-acetylcysteine, are fentanyl, which is at a very, very low dose, and a muscle relaxant. The other emergency drugs that need to be drawn and to be kept ready before we transplant or before we wheel in this patient is adrenaline, which is diluted, Lasix if is needed, atropine, glyco, and our ephedrine are basic drugs. We also use solumetrol and mannitol. This is just before we put in our new little liver. All right. Now, induction of anesthesia. Like I said, the arterial cannulation before induction if the patient is unstable. Rapid sequence for all, irrespective of. Once induction is complete and the patient is put on maintenance anesthetics, we then insert the central venous triple lumen line, preferably in the right IJV. These patients pose a challenge if either previously they have had lines in the right IJV and it has been thrombus. So if there is a history of ICU admission with a central line insertion, we always get a neck Doppler done to know, so we're not struggling in drop. So next thing you know, you've jabbed in a needle, you're not able to put the guide wire, but it lands up bleeding. So we need to know the patency of our right IJV, which we're going to put two wide bow lines inside them. Preferably the arterial cannula is put in the left radial, and we always connect the NIPP. That is never stopped. It may be on manual mode, but that is always connected. If patient is extremely unstable and we are expecting the patient to be on high inotropic support in the future during the transplant, we will then insert a femoral line. Again, it is going to be a little tricky because of the coagulopathy of this patient. Like we know, there are three phases of transplant. The first one is the dissection phase. So the dissection phase starts from the very beginning of incision to the portal vein clamping. Now, once the abdomen is open, we have to be ready for the pressures which are going to fall drastically, because we are going to drain the ascitic fluid. That fluid has to be then replaced by albumin. There is no obvious formula of how much albumin has to be replaced, but you understand once you walk through it is, you don't want to overload these patients, but you don't want to underload them as well. So, and the other thing is, once the TEG is done, we start preparing, because the surgeon will start complaining of bleeding. So before the incision, we have already preemptively started transfusing whatever products we need as per our TEG. So liver transplant patients are quite tricky, because our TEG also does not dictate exactly how much and which product is to be given. Sometimes the TEG is absolutely abnormal and the plane is beautiful. Where do we see the plane? When the liver is cut and the surgeon flips over the abdomen and you can see the cut surface of the abdominal wall muscles. If you see them dry and you have a bad tech, we do not transfuse. We don't over transfuse patients. So it's basically an anesthetist and a surgeon's decision as and when to transfuse. So this is about the dissection phase. The amount of ascites that is drained has to be calculated. Throughout this phase, we manage this patient's own drugs and fluids at maintenance levels. We also run these patients on dextrose because these patients, as you know, our liver is the one that produces dextrose. So they are prone to hypoglycemia. So there's always a dextrose containing fluid to which we add magnesium, and it is running at 80 to 100 ml per hour throughout as a carrier fluid with all the inotropes. Okay. So crystalloids versus colloids. Now this debate has gone in forever, but crystalloids obviously a pH which is as much as plasma, whether it's Kappa light or plasma light, and colloids preferably is albumin. We do not give too much. Gelofuscin is also used in many centers. We use it in Medanta as long as there is no anaphylaxis. The target hemoglobin during the dissection phase is around 9. We don't want a brilliant 11 or whatever, but we want to keep the patient stable at 9 grams. If any of this time during dissection, we realize that the patient is sinking. Why does the patient sink when we start seeing the SVR going low? There are many reasons. One is the patient is open. We drain the fluid. There's some amount of bacteremia that starts coming in. A little bit of sepsis, like we say. The patient is cold. So the patient starts now, you'll see the diastolic going lower. We can now maintain this by starting a little bit of noradrenaline as a background inotrope or a vasopressor. The dissection phase can be quite challenging if there are a lot of varices and sometimes the liver capsule ruptures or surgical reasons, and we may need to give transfusions, but generally in good hands, in experienced hands, it is a phase where we are preparing for a reperfusion. Then comes the anhepatic phase. So the anhepatic phase is a phase where there is no liver in the body, as in we have clamped the portal vein. In this phase, the coagulopathy can worsen because there is absolutely no liver in play. The little 10-20% of liver that was available in the dissection phase is now no more available. In this phase, we monitor the urine output, the ABG, and the TEG hourly, because we need to keep the patient physiologically absolutely stable. The patients get cold, the SVR starts getting low, the patient starts dilating. At this point of time, there is a chance that we may need to escalate the antibiotics if we see the patient getting worse. We need to, then comes in our liver from the donor. This is all coordinated with the donor OT or the donor surgeon. So then you have the cold ischemia. The cold ischemia is from when it is clamped but put in ice to when it is removed from ice. So that is your cold ischemia. Your warm ischemia has actually two parts. One is the warm ischemia in the body of the donor versus the warm ischemia in the body of the recipient till the reperfusion. All right. The other event is IVC clamping, when they need to do the anastomosis of the veins, portal vein, or of the hepatic veins. They need to clamp the inferior vena cava. But some centers do a complete clamping because it is easier for them and it facilitates their grafting better. Some people do a cross clamp. The advantage and disadvantages are, if you completely clamp, it's a quick procedure because you have no blood flow through the IVC. So they do their venotomy and then they do their anastomosis. If it is a partial clamping, we have lesser hemodynamic instability. Imagine no IVC suddenly, so yeah. So if we do a partial clamping, we have lesser hemodynamic instability. There is flow from the superior and inferior side. Hence, the kidneys don't bear a brunt. Otherwise, in case of a complete clamp, the kidneys bear a large hit. So complete cross clamp is avoided in patients with hepatorenal syndrome. We call this the renal protocol. So patients with kidney issues because of the liver are then we use renoprotective measures, whether it is antibiotics, whether it is keeping the patient warm, avoiding any sort of renal toxic, nephrotoxic drugs, or complete cross clamp. We don't completely cross clamp these patients. The explantation time is also very important, as in the time when the graft comes out from the recipient's body. Now we get ready for reperfusion. The graft has come in and the surgeon starts sewing. So it is the portal vein of the donor to the portal vein of the recipient. It is the hepatic veins. And the last, what they do after reperfusion is the hepatic artery and the bile duct. That is left for last. Before IVC clamping, there are two things that we give. We give methylprednisolone as in to avoid rejection, the bolus dose, and we also give mannitol, so it helps in a lot of free radical scavengers. It helps flush the kidneys out. So mannitol is given to the patients as 10 mg per kg dose. Arterial and blood gases again are done hourly here. We need to keep the ABG normal. In these, completely in this phase, the potassium goes up, the patient becomes extremely acidotic. So these are things that we need to keep. So there is a baseline infusion of bicarb going on in the background. And we also keep correcting the potassium. Either if it is hyperkalemia, we're going to hyperventilate, we're going to give a neutralizing drip. These are all the things that we do. Probably the calcium that we give, or the calcium that we give helps. And we also maintain the ABG, the pH with bicarb. We need to understand that we cannot give a lot of bicarb in these patients because we cannot let the sodium jump up high. If you think you're giving too much of bicarb, please change your fluid to half NS. So we're then compensating it there. Okay. Now, the patient just before reperfusion, it is the climax of the entire movie. The patient before reperfusion has to be as physiologically stable as possible, whether it is the temperature, whether it is the ABG, whether it is the hemodynamic stability of the patient, because the brunt that this patient bears during reperfusion, he has to be able to tackle it. At this point of time, arrhythmias are extremely common. Severe hypotension is a probability for which we have all the adrenaline and everything. And I'll tell you, there is no best way to do a reperfusion. And every reperfusion, we learn something. And I don't think there is anybody who can say that I do the best reperfusion. I know how to tackle every problem, because every reperfusion teaches something. Every patient comes up with a newer challenge. During reperfusion, we also keep a lot of colloids and ready as albumin or gelofuscin in case of hypotension, which cannot be tackled by inotropes. Now, the reperfusion phase. Okay, I think sir is saying we're running a bit late, but I will just finish up. So there is a portal bleed out that is done from the recipient end. So all the gut blood, which is the dirty blood, which has been stagnant for a while, it's bled out a little bit, and then anastomosed to the donor graft. And then we do a complete bleed out, which is the portal vein through the graft, through the hepatic veins out into the system. All right. So we need to be ready for the bleed out. Why do we do this? Because of the hypokalemic fluid that this graft has been washed with. And in case of any stagnant blood that is there, which is full of lactic acid on all metabolites, gets washed out. Reperfusion is a very challenging phase, and we have to tackle it with bicarb, lots of calcium, and inotropes. We need to have our adrenaline ready. A lot of bradycardias happen, whether it is, so we need to see whether this can be sorted with atropine or adrenaline, depends how bad your bradycardia is. And boluses of NORAD is required. A lot of fluids and colloids are given. Calcium has to be, like I said, calcium has to be given. This is especially given to counter the potassium, and soda bicarb is given to counter the acidosis. This is finally how we end our climax. And then the surgeon continues with doing his bile duct and his hepatic artery anastomosis. I actually felt I did a transplant while telling. I lived through it again, and it's never easy, but it is all the more exciting. And probably that's the reason I took up liver transplant. These patients are extremely fragile and very, very precious. We see through them throughout transplant. It doesn't end here. After reperfusion, it takes another good 4 hours for it to get over. These patients become cold. They need to be shifted to the ICU. It doesn't end there. The entire battle starts again. And hopefully they get extubated and they're stable enough to see their family.
Yeah, thank you, Dr. Shivani. It was as if we were also observing how the liver transplant is being done, and the total experience. We also felt the same as you are feeling it. So very nice. One thing I just want to ask you, because you said that you are using rocuronium for intubation, so instead of succinylcholine, any particular reason? Why do you wanted to go for rocuronium instead of?
Also, we give a good, rapid sequence dose of rocuronium, and we have all the facilities to, whether it is CMAC or Bujis, to know we can surely intubate these patients. If there is, we had this patient with difficult mouth opening. He was a tobacco chewer. That was a challenge where we use choline. Otherwise, rocuronium is what we use. Sir. No specific.
Yeah, just for the sake of students, succinylcholine can have a prolonged duration of action in patients with end-stage liver disease because pseudocholinesterase is metabolized in the liver. So there can be prolonged duration of action, but choice is, either one can go for succinylcholine or rocuronium. Not that succinylcholine is contraindicated as such as Dr. Shivani was also telling. So one can go for rocuronium also as such. But in India, yes, still rocuronium, we do not have Sugammadex and unexpected difficult airway. Definitely.
Sugammadex is like magic. When I saw it being used, and there was this morbidly obese patient, which we reversed with Sugammadex, I couldn't imagine that they would, reading about it and using it is another thing, where the patient suddenly all of it disappears and the patient starts breathing again.
Yeah, that is fantastic. Really, if we have Sugammadex, probably I think Sugammadex is being introduced in India also because Neon Laboratories, they are trying to introduce. So if it is introduced, definitely it will be of a lot of help. Every one of us can stop using succinylcholine directly. We can go for rocuronium for rapid sequence induction in majority of these patients. So nice discussion we had. Thank you so much, Dr. Shivani, and thank you, Pratyusha and Deepa. You people have really prepared very well, answered very well. Thank you so much. So you will do well. All the best for you when you take the exam. Both of you get CLD case for long case in the exam. You'll do much better. Thank you, Dr. Shripad.
Thank you, sir.
Thank you. Shripad, I have one question if you don't mind.
Yeah, please.
Shivani, it was an excellent presentation. I thought it is a live demonstration of the anesthesia conduct. Now the days have come with dual transplants, hepatic and renal. Do the procedures change? Anesthesia conduct changes?
So, yes, sir. So I have done quite a bit of, kidney livers, especially in hyperphosphatemias, all those syndromes and patients with HRS. So what basically changes is most of these patients all go on CRRT. So we have to have in mind that the CRRT has to be available and ready with the technician in the OT. And we have to have a line spared for them. So we can't use those lines for our patients. And these patients throw absolutely zero urine. So we are playing a lot with hyperkalemia. Last patient of mine threw 2 ml urine through those 16, 17 hours of surgery. It's heartbreaking for me to see 2 ml urine. So then we need to tackle with a lot of neutralizing, glucose, insulin infusions or bicarb. And we'll end up giving a lot of other things. So I reduce on my IV fluids because we're giving so much of bicarb and other things that we go down on IV fluids.
Yeah.
Thank you, Dr. Vijayanan, for joining us.
Yes, sir. You have any experience with robotic liver transplant or kidney transplants to your experience?
So, sir, robotic we do regularly. We do kidney transplants. We do a lot of robotic here. About liver, the surgeons are still learning the hepatic dissection part. So the donor hepatectomies are done robotically. The only thing it takes a very, very long time because they're still in their learning phase. But it doesn't change much, sir. It doesn't change. Probably blood transfusion in donors increase because the surgeons are in their learning phase. But other than that, no. And we have also stopped bleed out, sir. Normally, we would have first, if the patient, the donor comes with a 16 or a 18 hemoglobin, we would bleed them out to 2 units before we transplant. But now, if they're doing an open transplant, they do it so meticulously and beautifully that we don't give back those 2 units to the patient. So we have stopped bleeding them out.
What is your success rate in single transplant hepatic in your institution or in Bombay?
So it's a very, I mean, it depends on how sick the patient comes on the table. That's what I tell all my recipients. You get a good window to do a transplant. Take your decisions sensibly, because the sicker you come in, the more difficult it is, the more bumpier is your course for a recovery. So if they come in fit, I have extubated a couple on table. So it's
Great,
very
great, great.
rewarding when you tell them ki, sab theek ho gaya, and you're shifting them on a Hudson mask. It's very, very rewarding. So the reason I'd like to fast track is because these patients being on ventilator then are on immunosuppressions, then they land up with pneumonias. So I prefer to fast track if they're hemodynamically stable and physiologically stable. If we've not given too many units, if their ABGs are great, if he's attempting metabolized everything that we have given him, I will not think twice before extubating.
Because we are down in Bangalore, the standalone institutions who are doing transplants have a better success rate than in the institutions with general specialties and medical colleges, especially with respect to liver, I'm telling.
Sir. So, sir, what we've done in Bombay is there are six people who do only transplants. They don't venture into general. That is their subspecialty, and that is all that they do. So they kind of get better at it. You can't, like they say, you can't have your fingers in all the jars of honey, all your feet in all boats. So,
Thank you.
Thank you.
Thank you. Really great of you. My submission to Dr. Gurudat sir. It was a nice teaching. Thank you. Sripath, wonderful job. Keep up.
Thank you.
Gurudat sir, can I ask one question to madam?
Yeah, please.
Madam, thank you so much for this presentation. I just had one doubt because it's a little difficult at times, even we face this. Whenever we have these patients with massive ascites, and suddenly the surgeons open up and there is sudden decompression and the blood pressure falls very rapidly. You said there is no exact formula to give albumin, but how do we maintain? And sometimes the blood pressure can just go down to as much as 50 systolic.
I totally
agree with me.
I'll tell you two things. If you work with a sensible surgeon, he's going to know the amount of ascites. So what we tell him is, once you start draining, you stop the suction, you clamp it, you let us stabilize the patient. There is no need to drain all of it in one gush and go. It is not amniotic fluid where the baby is having fetal distress. So a little bit is drained, and if I see that the patient is getting hemodynamically unstable, he stops this draining, and we then stabilize the patient. Whether it is, so how we give albumin here is, we take our 20%, we put it in a half a liter of Cabilite or plasma light, and we give that as a colloid. So we can rush it, while you cannot rush a neat albumin vial.
Yes, ma'am. So in case if it doesn't do and the blood pressure falls to very drastic 50 systolic, so what are the different ways you can bring it up?
So NORAD is always on. There is frenin boluses, and the only way to transfuse is to transfuse colloid. Is to transfuse albumin.
That's the only way, right, ma'am?
Yes.
And I'm sure there is no volume as such how much to be given, right?
No. There is nothing obvious, because we don't want to overload these patients. These patients have to tolerate, especially in transplant, have to tolerate a reperfusion. You can't have them with volume overload and suddenly all that gush of reperfusion stuff coming in, and then you have a cardiac failure. So it is a fine balance between giving volume and inotropes and then tolerating the reperfusion.
Thank you, ma'am. Thank you so much, ma'am. Once again, fantastic.
So I read in one of the books that maximum amount of albumin you can give is 1 gram per kg body weight.
So it depends again.
Maximum. I mean to say that it is the maximum amount. So 20% albumin if you are giving, so 20 grams in 100 ml. So in a 60 kg patients or 50 kg patients, maybe about 200 ml or 250 ml of albumin maximum. I think you can give.
So if colloid is required quite a bit, and we know we've gone a little overboard with albumin, we don't shy away from using gelfuses as long as there is no allergy. Because I have seen severe allergies with gelatin, which I have then decided that I give a test dose of gelfusin before I use it in any patient henceforth.
It was more common with Himaxil.
So
than gelfusin. Gelfusin is supposed to have less prophylaxis.
The donor systolic go to 30, and I thought it was a portal bleed. Then I thought it was my outline, and I purged the same gelfusin, thinking it's hypotension. So I actually till today my residents laugh when I take 1 cc, dilute it, and give half a cc of that to see if there's no allergy or not. It's once bitten, twice shy.
Better not to use at all then. Better to go for crystallites only, balance salt solutions instead of gelfusin or Himaxil.
Sir. The chain, there is a drastic difference. Whatever people say, the kind of intravascularity that the colloid has, the rise in blood pressure is not possible with a crystalloid.
Only crystallites. Yes. That is there. And it's going to dilute all other
and these
the other factors
anyways, vasodilated, they're overloaded already. When you take them on table, it's not shown, it's not obvious, but it is there in the system.
Thank you so much. I think over to Shripad, because still Dr. Bangera's lecture is there.
Thank you, Gurudas sir, for your eloquent exam of our students. I hope everybody did well, and it was very fruitful session for all of us. And thank you, Dr. Shivani.
Thank you,
and
sir.
We are proud to have you here.
Thank you, sir.
I'm
a student, sir. I proudly say I'm a student of Shema.
It is very nice to learn from our students. When students grow up and start teaching us, it's a wonderful feeling for us. And it was a very good session. Thank you so much for joining us. I know you had some work going on at the background. Still, you could make time to join us and teach our students. Thank you so much.
Thank you, sir.
And a lot of seniors have joined this session. I thank everyone. And we'll move to the next session by Dr. Anand Bangera. He is going to talk about anesthesia gas cylinders. One unique topic which only few people can manage, I believe. Over to Dr. Bangera.
Thank you, Dr. Shripad. After that very interesting discussion of hepatic transplant by two teachers. One is a very established teacher and my teacher. The other one is my student, who also today taught us very nicely. She has taken us into the theater of hepatic transplant. Because for us, we have not seen so far hepatic transplant. So she as well as sir did a great job. Congratulations and thank you, sir. Now, this particular topic of anesthesia cylinders, I think I'll restrict to maybe around 15 minutes or 20 minutes, not more than that, mainly with the PG orientation. So anesthesia gas cylinders, generally a cylinder term is used to describe a pressurized container used for storage and transport. And for that reason, a cooking gas cylinder for a homemaker and any of the anesthesia gas cylinder for a anesthesiologist, both are equally and very, very important. So, as we all know, invention of oxygen and oxygen cylinder is one of the most important developments in the field of medical practice, be it for us anesthesiologists or any practitioners concerned with managing emergencies. So when the anesthesia got evolved in the initial stages of demonstration of anesthesia, the oxygen was not used. Maybe when ether, Martin demonstrated ether, he didn't use oxygen. But later, to prevent hypoxia, they started using or placing an oxygen catheter, and that made the requirement to have an oxygen source mainly through a oxygen cylinder. So now there are different anesthesia gas cylinders, the older being the cyclopropane, all those things. The most recent could be heliox and other things. Now coming to anesthesia gas cylinder particularly, so this is the common question that is asked in the exam. What is the material used to manufacture the cylinders and why it is so? Earlier there used to be steel was the material. Now it is molybdenum steel. Molybdenum is added to give a extra tensile strength, and because of that also it can accommodate at least 20% of more gases. It makes the cylinder lightweight, giving a high tensile strength. But in the present day practice of the medicine, where we need to MRI is very much required, and we need to give anesthesia in MRI stations, we need to have special cylinders. So aluminum cylinders are made available in the MRI suits. Now, as I said, there need to be a lot of safety features. One of that is being the color coding. We need to identify the cylinders properly, preventing the misconnection of a cylinder, and thus to prevent hypoxia. So all the cylinders are colored. For oxygen, it is black body with white shoulder, and for nitrous oxide, it is French blue, and so on. And this is the aluminum cylinder that I was discussing about. And I said the cylinders are made up of molybdenum steel with high tensile strength, but it is made up of a single block. That means there is no welding point. If there is a welding point, that would be the weakest point, and it can yield when the pressure builds up. So to prevent that, it is made up of a without a seamless material. Now, what are the parts of the cylinder? The cylinder you can divide it into the cylinder proper, the body proper, and the cylinder wall. This is the cylinder wall. This is the cylinder body. Body you can further divide into the body proper, the shoulder, and the neck. Okay, here I can explain a little more. This is the cylinder, and this entire thing is the cylinder wall. In the cylinder wall, one side we have, this is the stem which goes through and through, and this particular exposed part is called as the spindle. That is the one which you rotate either to open or then to close, always clockwise to close and anti-clockwise to open. This is the gland nut, which we are not supposed to open it. Only the service people, they open it to adjust the pressures. And here on one side, we have the exit port through which the gases flow, and below which we have the holes of the pin index safety system. On the other side, there is a depression. We call it as the conical depression, and below which there is a pressure relief device. Onto this conical depression, the retaining screw of the hanger yoke assembly sits, and you can tightly or snugly fix the cylinder into the anesthesia machine. So this cylinder wall is threaded into the neck of the cylinder using a Teflon material. Right, this once again I am explaining here. This is the spindle, gland nut, okay, valve stem which goes through and through. Okay, here you can place the Bodox seal or the sealing washer. This is the exit port, and these are the holes of the pin index safety system, and this is the screw thread which goes into the neck of the cylinder. The cylinder walls can be of different type. What we use in the anesthesia, what we attach to the anesthesia cylinder is the pen index valve type, whereas in the cylinders which is available in the ward, it is of a Bowman's type. So what are the different sizes of the cylinders and what cylinders can be mounted to the anesthesia machine? These are the different cylinder sizes, out of which E size is commonly attached to the anesthesia cylinder on the sides, whereas a little bigger cylinder, that is anesthesia F, can be attached on the back side of the anesthesia machine. Okay, here I have mentioned the pressures of the different sized cylinders and also the tear weight, that is the weight of a empty cylinder. So the student should know the different markings on the body, the shoulder of the anesthesia cylinder. Okay, where it is mentioned the name and chemical symbol of the gas, the hazard, that there will be a diamond shaped figure that indicates that all these cylinders, especially oxygen cylinder, is hazardous, so we need to be careful. Name and address of the cylinder manufacturer, cylinder contents in liters, the tear weight, all those things will be mentioned. Now, this is one particular question that is asked to the students. What is the cracking of a cylinder and why it is done? Cracking of cylinder is the sudden opening of the cylinder, placing the exit port away from the person who handles the cylinder. Okay, this is done so that the grease, dirt, or dust which is there in the exit port should come out, so that by chance if it is there, when you open the cylinder, there may be a creation of adiabatic effect and there is a chance of explosion. So we need to do this cracking of the cylinder before you fix the cylinder into the anesthesia machine and then you open the cylinder. Okay. Now the color coding systems is very, very important. We still use here, or we still have here, the old color coding systems, but we should also know that recently the newer color coding systems have come and all our students need to by heart these color coding systems. For oxygen in states it is green, whereas here it is white with the black body with the white shoulder. Similarly for different other gases. This one we should remember. Nitrous oxide, it is French blue, and Anthrax, it is blue and white strips in the shoulder. Same thing I have explained here. Now, if you keep the cylinders sometimes under sunlight for a long time, there may be building of pressure. When the pressure builds up, there is high chance of explosion of the cylinder. So there should be some safety feature, there should be some mechanism so that this sort of untoward incidents should not happen. Okay, so we have different pressure relief devices. Okay, by these devices, the gases are vented into the surrounding, into the atmosphere, so that the sudden high pressure that is built up is reduced. These pressure relief devices, which generally are placed here, this part of the cylinder wall, can be based on the pressure, based on the temperature, based on both these, and the different types of spring loaded, the fourth type of pressure relief device, that is the spring loaded pressure relief device. Okay, the one which is based on pressure, we call it as the rupture disc. Okay, made up of copper gasket. When the pressure builds up, this disc ruptures and the gases gets leaked into the atmosphere. Whereas the other type is the fusible plug, made up of different metals, including bismuth, lead, tin, and cadmium. And the temperature builds up, the this particular Woods metal gets melted and the gases gets leaked into the atmosphere. And I said there can be a combination of both. And this pressure relief valve or spring loaded valve is a spring-loaded designed to reclose and prevent gas in cylinder from being discharged after a set pressure has been restored. Okay, that means it is a non-returnable type of device. Now, what is the safety precaution advocated to prevent connection of a wrong cylinder? Okay, especially when you order on a OT attender to get a cylinder, there is every possibility that he can get a wrong cylinder or whatever cylinder that is available for him. So we should, there should not be a possibility, even intentionally, if you connect a wrong cylinder, you should not be able to connect a wrong cylinder. What I mean to say, even if forcibly you connect a nitrous oxide cylinder in the place where oxygen is supposed to be connected, should not be possible to connect the cylinder. So that is done by what is called as the pin index safety system, which is first introduced by Philip Woodbridge in the year 1952. So this is what I was telling you, the pin index safety system. On the cylinder wall, we have the different holes of the pin index safety system. Correspondingly, on the hanger yoke assembly, we have the pins of the pin index safety system. These holes, the different holes are different for different gases. Okay, so they are arranged in a arc-shaped manner with a specific radius of around 14.3 millimeter, with the exit port as the center, with a specific diameter of around 7 millimeter, and each hole has a diameter of around 4.75 millimeter. So the placement of these holes, as I said, it is different for different gases. So if you can see here, these are the different holes. For oxygen, it is 2,5, whereas for nitrous oxide, it is 3,5. If you see closely here, the holes of oxygen are widely placed, whereas it is a little closely placed in place of nitrous oxide. So this is 2,5 for oxygen, 2,5 position for oxygen, whereas this is 3,5 position for nitrous oxide. Okay, so maybe you can by heart like this to remember the positions of different gases. So if you remember like this, 1, 2, 3, like this, for air it is 1,5, for oxygen it is 2,5, and for nitrous oxide it is 3,5. 1,5, 2,5, and 3,5. For carbon dioxide more than 7.5%, it is 1,6, less than 7.5 it is 2,6, and for cyclopropane it is 3,6, and for Antonox it is only a single number. Okay, now there should be some other specific safety features to prevent bursting of the cylinder. So you have to check the pressure, the tensile strength of the cylinders very periodically. There are different tests called as hydraulic testing, flattening test, impact test, and bend test. I will not be discussing all these tests, how it is done, for the lack of time. Now, these are some of the things which the student is supposed to know: how you calculate the content of oxygen in an oxygen cylinder using Boyle's law, and similarly what gas law is used to calculate the amount of nitrous oxide, because it is in a liquid phase. So that is by using Avogadro's hypothesis. So after this, so these are the safety features. One is it is made up of molybdenum steel with high tensile strength. color coding, which I have discussed. It is made up of seamless body, safety relief valve, and the pin index safety system. Now, what object is used to prevent leak between the cylinder and the yoke when it is attached to the hanger yoke assembly? This is what is called as the washer, or it is called as the Bodox seal. It is not a simple thing, because it has a inner rubber part made up of neoprene and a outer metallic ring. The outer metallic ring is to prevent wear and tear, and the inner rubber part to have a better airtight seal. The next question that is usually asked is, both the pipeline as well as the cylinder are attached at a time. The gases flow from which particular source, the cylinder in the machine or from the pipeline system? It is always from the pipeline system, because the pressure in the pipeline system is slightly above that compared to the that of the cylinder outlet. It is around 60 in case of pipeline. It is around 45 to 50 in case of cylinder, because the cylinder which is attached to the anesthesia machine should be always as a reserve. Still, if there is leak, there is what is called as a yoke plug. If that yoke plug is there, that will prevent the leaking as well as trans-filling of the gases from a full open cylinder into a other empty cylinder, right? So storage of cylinders is very important. You have to store the cylinders in a cool, dry, very ventilated place, mainly to prevent dampening as well as to prevent explosion. There should be good access, and you should always mention whether the cylinders are full or empty. Otherwise, there will be confusion. In an emergency, the OT personnel takes an empty cylinder, and we will be in trouble always. Okay. As I said, it should be stored under, should not be stored under direct sunlight, should be easily visible, and it should not be exposed to corrosive chemicals and whatever agents that can support the combustion, right? The temperature should be adequate, should not be too much more, or should not be less. Also, there should be a chaining system so that it should not fall down. There should not be chance of explosion, and there should not be there should be a one specific trolley which is specific to carry these cylinders. Handling and installation. Okay, so you should before you fix, you should correctly identify. Though generally the cylinders are fitted with a seal, so that you should remove, and you should do cracking of the cylinder, which I have explained. There should be only one Bodox seal. If you place more than one Bodox seal, the pin index safety system gets nullified, so you can connect inadvertently a wrong cylinder, and the valve should be opened very slowly to prevent explosion of the cylinders. So these are the different basic aspects of a anesthesia gas cylinder. Once again, the safety features are very important. The make, the color coding, the specific seamless body of the cylinder, different safety relief devices, the pin index system, so to to prevent connection of a wrong cylinder. So in whatever time that was allotted to me, some basic aspect of a anesthesia cylinders I have explained. Thank you. Thanks a lot. Thanks to Dr. Sripada and the team of Nitte Anaesthesia Education Series. Thank you.
Thank you, Professor Dr. Anand Bangira, for this wonderful session. As always, Dr. Anand Bangira has excelled in making the matters very simple. And within a given time, he has covered almost the entire topic. At least he has given direction to study what to study and what not to study. Thank you so much, Dr. Bangera.
Thank you, sir. Thanks a lot.
And this is our 12th episode. So I'm very, very grateful to all of you, all the faculty who joined us and did wonderful sessions since last August 2021. And I'm especially thankful to today's faculty, Dr. Lakshmi, Dr. Gurudat, Dr. Shivani, Dr. Anand Bangera, who delivered wonderful lectures and discussion. And we lived through the liver transplant, though we are not much exposed to it. We lived through it. So thank you so much for your great insights which come from vast experience. Also, I'm thankful to our students, Dr. Deepa and Dr. Gauri Pratyusha, for preparing well and presenting so nicely. It made the discussion very lively and very useful to all the faculty. I'm especially more thankful to inspiring presence of so many of our senior colleagues, whether it's Dr. Vijayanan, Dr. Bindu George, and Dr. Azam, Dr. Anil. So many of them are. What I see is what trend I noticed through our online series is that more than the residents, the senior faculty who join us, and most of the times they are present through the proceedings. This is very inspiring to us to conduct such programs. And I'm very sure that because of your presence, we made up mind to continue it every month till now. And I'm very, very grateful to all of you who joined us, who helped us, encouraged us, inspired us, and also involved us in the program. Thank you so much. I thank our Nitte management for supporting this program for all these years. They have supported not only the online program, the offline program, various conferences, events, and our day-to-day activities in a wonderful way. And we are proud to be associated with Nitte for that matter. And I thank our office staff, all the infrastructure given by Mr. Mahesh and his team, Ms. Bharati, and all others, faculty development program directed by Mrs. Sadhana Deshmukh, and all of them have supported us unstintingly and made this event possible and smooth and effortless to us. Not to say the least, my colleagues who were always the backbone of this program, they scouted for the faculty, they communicated with the faculty, they contacted, they started the program, they conducted, they concluded. Most of the times, only very few times I was on the program, and the rest of the times, whether Dr. Suma was organizing secretary for this, or all other my colleagues, they were holding the fort for me, and they made this event possible for all these days. And they gave also wonderful publicity to the program so that all of you could join us. So I thank all my colleagues and my residents for making this event successful. And then finally, we thank our only one who is taking care of us, Almighty. I thank everyone again. If I miss somebody, it's not it's all inadvertent, not intentional. So please do join us again whenever we have programs. Thank you so much, and look forward to be associated with you in some or other way. Recently, we had an online transthoracic echocardiography event workshop, which was excellently conducted by our in-house and out-of-house faculty, Dr. Rajesh. And it was a grand success because more than expected people joined the hands-on workshop. And it was a runaway success. Like that, we are going to associate with you more and more, whether it's upcoming conferences or our in-house programs. I again request all of you to join us in all possible ways and keep in touch. Thank you so much. God bless you, and thank you so much again. Have a good day, good times.
Thank you.
Thank you.
Thank you, Shrikant sir and Suma madam. Thank you so much.
Thank you so much. You are a wonderful person. Thank you.